Oh,
Good afternoon, good morning, everybody. Welcome to our post-acute stroke month webinar series. This is a great presentation that we have for you all today on patient-centered care and stroke rehabilitation. I will share some slides here. Okay, oops. I might have given my slide control over and now don't have it back. There we go. All right. So I would like to first to welcome Amy Shipley and Erin Kemperman. So Amy is a medical speech language pathologist at the Queen's, sorry, I just lost my page, at the Queen's North Hawaii Community Hospital and adjunct faculty at the University of Hawaii at Manoa. She specializes in stroke rehabilitation, dysphagia, cognitive communication disorders, and interdisciplinary rehabilitation across the continuum of care. Amy has over 13 years of experience in acute care and outpatient rehabilitation with clinical leadership experience at Stanford Healthcare, Hilo Medical Center, and Queens North Hawaii Community Hospital. And Erin is joining us from Seattle, Washington. Erin has a master's degree in nutrition science from the University of Washington in 2009 and has been a lead dietitian role for Swedish Medical Center since 2011. She's a certified nutrition support clinician and helps to develop the malnutrition diagnosis protocol for the Swedish hospital system. I'm adding my own 2 cents here because I've worked with Erin and I think she's a fantastic clinician and educator for patients, family, staff, and students. So really excited to welcome Amy and Erin. Just some housekeeping slides. The recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the Heart Association. The American Heart Association does not endorse any product or device. And just some housekeeping, everyone is muted. Our panelists will be the only ones on camera. This session is being recorded and we will post it to our South Dakota website following the webinar today. So you'll be able to access it, watch it again, or share it with anybody. If you have any questions, please use the Q&A option and we will ask those questions and answer them at the end of our session today. If you have any technical issues, try logging out and coming back in. Otherwise, send us a message and we can try to help you troubleshoot. If you have any questions afterwards, feel free to connect with me. I have my email address up there, and I can get you connected with Amy and Erin. All right, so I will stop this and share our next. Oops. Okay. Okay. And I will hand control over to Amy.
okay, cool. Will I be able to view the chat, even though there's questions that will be fielded at the end, Caitlin?
I'm not sure if you can see it
Okay,
currently, but
give
I
it.
will keep an eye on it and maybe
Okay. So
let
it's
you.
1 p.m. for you folks on a Wednesday. In the chat box, if you could go ahead and let me know what you do for a living. We're a small group for the live session today, and I'd love to know who we have on the call. We'll just take a minute and do that really quickly. Because there might be some stuff that I gloss over if I've got a bunch of physical therapists. Okay, no pressure, SLP and program manager. Caitlin, I could
I started
successfully
this off.
see that. Yeah, good. Okay. Anyone else, go ahead and tell me what you do for a living. And then after a few minutes, maybe Caitlin, you can jump in and let me know what the chat box says.
You
I'm
got
not
it.
seeing any other responses. I'll quickly introduce myself. I'm Amy. I'm a clinical speech pathologist, and I also mentor graduate student clinicians, and I teach a dysphagia course. And my career-related mission is to help speech language pathologists be trained in Hawaii and practice in Hawaii at the top of their license. And that obviously means staying on top of evidence-based practice. And as many of you know, taking care of patients that have had a stroke is essentially the meat and potatoes of what we do, and it inevitably constitutes a large amount of our caseload. So today I'm going to be tying in some of the latest and greatest treatment techniques, and we can discuss what do patient-centered goals and care look like. Oh, okay. The Q&A. That's all right. If you can use the Q&A and let me know what you do, that would be cool. But if not, I think we need to move on as we have limited time. But thank you for your time and attention today. And I do want to say one thing. I know what it feels like to practice in an under-resourced area. And while we try to stay up on our practice patterns, sometimes it's really frustrating. I went to a course, I think it was a couple of months ago, and there was this Southern California-based Kaiser doc that was presenting about the order set and hospital bundle that they had for ischemic strokes and for hemorrhagic strokes. And it was like, here's all the systems that we have in place, and here's all the resources. And I know and understand that sometimes we don't have those resources. And I find myself doing all kinds of things that I never thought would be on my list for the day because I'm in an under-resourced community. And I'm going to go ahead and say that that's part of rural healthcare, and that's also kind of what makes it magical. I'm going to move on to the initial slide, and we'll talk a little bit about what do speech pathologists actually do. So it's actually the worst job title ever. It's very rare that we address a true speech sound impairment. As med SLPs that are working with the adult population, we're going to see people who have impaired swallowing. We're going to see people who have language impairment, a hard time understanding what they hear, comprehending what they read, um, putting their thoughts to words or actually coordinating the articulation patterns that they need for clear speech, right? A lot of times we help our patients get access to communication. And I apologize, the acronym on the lower right-hand corner of the screen is inaccurate. Notebook LM made these slides for me, but it's augmented alternative communication. And there's a lot of ways that you can augment communication. A lot of you folks might think about just those general med SLP communication boards where the patient has the option to point to a symbol or to words that talk about what they need. So SLPs have training in that. We think about how can we get this person access to the communication that they need, whether that's low tech and no tech, all the way up to a speech generating device with eye gaze technology, right? Also, we address the cognitive aspects of communication. Can our patients pay attention to participate in a conversation? Do they have the working memory to hang on to that back and forth exchange when they're communicating with a healthcare provider or with their loved one? Do they have the self-monitoring skills to recognize when they make an error and to repair? So these are all things that we do. And I can't tell you how many times I've walked into a patient room and I've said, "Hi, my name is Amy Shipley. I'm a speech therapist." And they'll say, "My speech is fine." What are you doing? And then I have to explain, you know what? I'm here to make sure that you're eating and drinking with ease, or I'm here to actually check on your thinking. And so I feel like a lot of what we do as speech language pathologists is misunderstood. And that's like at the root of the sort of host of issues that plague our field. So when Caitlin reached out and invited me to share with you today, I jumped on it. It's also part of my mission. Um, so that's a little bit about our scope. And I know that we have an RN in a critical access hospital. I'm not sure who else is on, so sorry if that was redundant or information you didn't necessarily need. We're going to talk about the questions that we ask ourselves as we're providing patient-centered care. I was trained in speech pathology in 2013, 2012. Oh man, I'm trying to change the slide and it's taking a while. Come on. Okay. So a lot of times we have to rely on screening measures and standardized measures. And they do have a very good purpose. Of course, the NIH stroke scale is invaluable. That's an objective way for us to quickly gauge how severely has this CVA impacted our patient's function. But really, when we're at the point where people are medically stable and we're thinking about rehabilitative efforts, speech language pathologists are going to go straight to function. What does my patient need to function in their current environment? What can I do to help them optimize their quality of life right now? Again, going back to that previous slide, thinking about cognitive aspects of communication, accessing communication at all, maintaining swallow function for adequate nourishment, hydration, and then also, language and speech. So, when I was trained initially, I was at LSU's Allied Health School, and I had an amazing professor in aphasia. And a lot of what we learned was how to facilitate standardized testing to get an impairment profile. And I would be able to get standardized scores and index scores and talk to my patient about where they lied on the bell curve. And what I found was that most patients do not care about this, right? And if you look towards the right of the slide, they want to be able to use their call bell so that they can get out of bed and go to the bathroom. They want to be able to text their grandkids or FaceTime their loved ones. They want to be able to make that order at Starbucks, participate in their weekly coffee talk, go to church, sing in the choir. So we really do think about that direct restoration for the priority life roles. And sometimes that means physiologically that direct retraining, where we think about improving sensory motor function, where we think about lesion location and we think about that period of time where the brain actively heals after a stroke, right? Especially with the case of ischemia. But also, we're thinking about compensating and we're sort of balancing that in a speech pathology session, right? Okay, I see that my patient has such a severe motor speech impairment that he garbles his words when he tries to tell the person from the bank what his social security number is. How can I help him compensate for that? Because maybe exercises won't fix it right away. And so we're always thinking about that. And that personalized care really depends on what the patient's priorities are. And I'm sure that Caitlin can relate to this, but we really do frame our treatments in a very patient-specific way. I mean, that's our job. So really, an initial session for me starts with forming a therapeutic alliance. Hey, I'm Amy. What's important to you? You want to get home? Let's get you home. You want to eat cantaloupe today? Let's get you that cantaloupe. And I think from there, after we have that trust, we can continue to address functional goals. Does that make sense? I feel like a lot of people imagine what we do as speech pathologists, and it's hard when you don't see it and when you're not in the session. Maybe you imagine an SLP holding up a picture of an apple and prompting that patient to say the word apple. Is that an evidence-based therapeutic technique? Yeah, but the brain heals even faster if that patient works in an apple orchard, right? Or if they really want an apple, or if their daughter's name is Apple. Um, anyways, so that's a little bit about functional questions. And we're considering just moving beyond fixing a deficit to addressing every aspect of what the patient needs. And actually, a big part of that now is what we call digital IADL, so having access to smartphone usage, texting. And I do a lot of functional treatment surrounding that after folks are out of the hospital in the subacute or outpatient settings. Um, we're going to transition now to dysphagia management. I'm almost going for too long, so I'm going to try to speed up. Um, there's a lot that I can say here. Pressing the button. I know that this is the most abused analogy in all professional presentations in the world, but it was very appropriate. When you think about speech pathologists and how we manage dysphagia, certain terms might come to your mind: aspiration pneumonia, modified diets, pureed solids, nectar thick liquids. But really, our practices are so much better informed now in 2026. Back then, in 1998, when we had the late and great Susan Langmore sort of pull out some risk factors for what creates aspiration pneumonia. There are some unnecessary acronyms on this slide, but let's go ahead and talk about them. Stroke-associated pneumonia is definitely a mortality risk with people status post CVA. But the daily reality behind that, is that there's many patients that deal with eating related fatigue, and the psychological toll of eating a modified diet has a huge impact on our patient's function. Now, let me back up. When I say eating a modified diet, I'm talking about diets that have been changed in terms of their texture. So maybe you've had a patient participate in an SLP evaluation and that clinician recommends pureed solids, right? Or maybe that clinician recommends minced and moist solids. Or, God help us, maybe that clinician recommends thickened fluids. I don't know if any of you have ever had modified fluids that have been thickened. I encourage you to try. So Amy Shipley told me to try this. Toss and back the mildly thick cranberry, see how that feels. But we know now that those modifications are associated with malnutrition, dehydration, a dip in, excuse me, psychosocial status. And honestly, they're good to avoid if we can. Mm. But also, dysphagia creates a cycle with depression and anxiety because one of the biggest things that we do with our families and with our friends is go out and eat, go for coffee. And it's something that is really easy to take for granted. Um, so we've got a personalized dysphagia management, and that starts with some really objective clinical stuff. We've got all of this really cool framework. There's a bolus framework where we can very objectively sort of mitigate risk with evidence-based variables. Is my patient's mouth clean? Right? Is my patient awake, alert, and able to participate in the act of eating and drinking? How many comorbid diseases does my patient have, and what does their medication profile look like? So, your speech language pathologist is considering all of these things as they make swallowing observations at the bedside, right? Does my patient need to participate in a more advanced or objective evaluation of swallowing? Do they need the camera in their nose or the video fluoro, the X-ray evaluation of swallowing? And generally speaking, we're considering all of those things, and we're also considering what's important to the patient. Mm, Does the patient have a graduation party that they need to attend in a few weeks? And is it really important that they eat cantaloupe? Um, are they opposed to having really cold foods? So there's a lot of things that we try to do to improve quality of life. But I'm going to say this after I drink water because I have upper airway irritation right now. Where my brain goes, and I don't know if Caitlin can relate, but with the stroke population, after people are medically stable, I think immediately about sensory and motor reintegration and rehabilitation. And the best way to rehabilitate an impaired swallow is by swallowing food and fluid. So sometimes if we have a patient with a dense impairment in their throat or in their oral cavity that puts them at high risk for food getting stuck or going down the wrong way, we're going to find a way to directly improve that function. Mm. And one of the safest ways to do that is with clear, thin water or cold, clear, thin ice chips. Excuse me. We want to be managing our secretions, getting sensory input, swallowing our saliva throughout the day. So it's very rare that a patient should ever be strict NPO. If you have a patient that's strict NPO with a temporary source of alternate means of nutrition or a more permanent one, you should ask yourself, oh, do I need to ask speech? Should my patient be having ice in conjunction with oral care or small sips of water? Or what are we doing to facilitate oral intake with this patient? And I encourage you to reach out to your speech pathologist and ask them those questions. If there's someone on your mind, I'm not sure if that's something that happens with your setting. Thank you for listening to my TED Talk about that. We're now going to transition to aphasia. And the term aphasia refers to language loss after stroke. Um, and a big part of this now, with the most current research, is all about life participation. And I briefly touched on this earlier, but it's 2026, it's not 1998. Even though I love the fashion from that era, a big part of what we're doing is thinking about how can we help our patients participate in their lives. what photos and emojis do they need? What do they do? What did they do prior to their stroke that was social and important to them? And how can I help them access those activities? And again, we're always thinking about that balance between direct restoration of function and compensation. So I hope that that makes sense. I'm going to try to move a little bit more quickly. The next slide is about cognitive communication. Um, and we're just going to briefly touch on right hemisphere damage. Mm. This can be a really tricky condition, and it can also, I've found in my practice, bias healthcare providers. It's a really good idea to pay attention to the lesion location of a stroke. Oftentimes, if patients have lesion or damage in the right hemisphere, we'll see what are called cognitive communication deficits in the absence of a language or speech impairment. So these are our patients who sound fine, who are able to make, syntactically appropriate statements. They'll say things that make sense grammatically and are in the right order, but maybe you can tell right away, like, oh, this patient has a cognitive impairment. Oh, wow, this is really hard. This patient's not going to be compliant with his blood pressure medication at all because he's not able to pay attention as I educate him. Um, when you have a patient with this kind of issue, it could be that you're working in a setting without speech or that you have limited speech. And you might want to call and consult speech and say, hey, Mr. Frank had a right hemisphere CVA, and I'm noticing these things. Can you come do a quick screen or eval? Because he might need to discharge to a place where he can get cognitive communication therapy. This kind of therapy with what we do is so understated, so magical, and so helpful because it's very, very functional. And again, what we're doing is tying in what's important to the patient, helping them to develop insight about where their errors are, helping them to get the internal and external strategies that they need to help remember functional information, to help pay attention, to help self-monitor, and to plan and execute and problem solve. I'm going to be helping a patient next Thursday with planning a big move across the country. And his thinking is very disorganized, but he has coherent thoughts. His stroke was in the right hemisphere of his brain. I think I'm going over. Sorry, I'll be quick. Communication is healthcare access. Hmm. Miscommunications can result in a lot of adverse health outcomes, and that has been lightly researched. If you have a patient with a speech, language, or cognitive communication impairment, they may not be a reliable historian for those reasons. They may not be able to effectively communicate their symptoms, provide informed consent, and SLPs can help with that. Consult us. Even if, excuse me, your facility does not have the staffing, consult us so that we have the data to show that we were consulted so that we can work on getting a position created because there needs to be more speech pathologists in the world. So that's about that. And then I think I just have a few more. Um, Caregivers with the stroke population definitely experience the stroke right along with them. So having that social support is also really important, and caregiver burden is absolutely no joke. Friendship support definitely moderates this risk. And so if there is a support group available in your area, whether that's remote or in person, you should definitely have a lot of flyers about that group going. And if you have the bandwidth or if you have a colleague that would be interested, start one at your facility. You can meet quarterly for an hour. It can be a low effort, high impact thing. And I've found that hospital admin really love this because it's huge. So we need to support our caregivers. And generally speaking, this is one of the things that we're thinking about with the continuum of the stroke recovery. All of you probably know this, but we've got this sort of acute phase where we're hoping that, there's no hemorrhagic conversion of the stroke. We're not sure when the door to TPA time was, and how the patient's doing. But the SLP's role during that acute care phase is generally very dysphagia specific. So, strokes that are Joint Commission stroke certified have to address physician orders for SLP swallow eval within 24 hours that they're set, I believe. Caitlin, jump in if you have any other data that says otherwise. Um, and really, what we're doing is a clinical evaluation, and we're saying, okay, do we assess any sensory motor impairment or any signs that show that this patient might have a pharyngeal dysphagia? Or a swallowing impairment from dysfunction in the oral cavity? And if so, what are the interventions and further diagnostic tests that we need to do to facilitate a means of nutrition, hydration, and medication? Really, that's the meat and potatoes of your SLPs in neurocritical care and in acute care. They might have time to do a speech, language, and cognitive screen. Um, and then once patients are medically stable, once they're out of the ICU and maybe navigating a week-long hospital stay. Hopefully, it's not that long. Once they're in a subacute rehab facility or getting home health or in the outpatient clinic, that's when we can really address the other areas. If they still have a dysphagia that's affecting them, if they have those cognitive communication, speech, or language deficits. And that rehabilitation phase, it's nuanced and it's patient specific. It can be from week one on, going through a year. Sometimes I'll pick up people on my caseload who had their stroke 5 or 6 years ago because I can see that they don't have compensations to help them do what is important to them. So we're not always just thinking about that, 3 to 6 month spontaneous recovery period. I also think we could use better data about that. And finally, the last and final phase would be reintegrating the patient or providing assistance with reintegrating them into the community. I have a couple of case studies, but I think we're actually gonna not do those because we're out of time. Um, but again, you can review the slides. And these slides kind of deal with intersectionality, a whole patient, and provide an example of what a speech language pathologist would consider as they support the patient. Um, we are trying to not necessarily fix every deficit, but what we are trying to do is improve our patients' ability to participate in meaningful activities, and improve their quality of life overall. And that's what speech language pathologists think about. We want to talk to you, we want to be consulted, and we want to really support our patients. Yeah, so if you want to continue the conversation, or if you have any questions or concerns regarding the content, I know that Caitlin wants to have some time afterwards, but that is also my email address. Feel free to reach out to me. And then I also have, a slide with the sources from today's presentation. Thank you so much, and I'm really excited to hear from Erin because I know that Erin is amazing and their field is also amazing.
Thank you, Amy. That was amazing. I will switch over to Erin's presentation now. And for everyone who has joined us today, feel free, if you have questions that come up during either of the presentations, feel free to throw them in the Q&A now, and then we can address those at the end, or you can wait until the end for those questions. But I will turn it over to Erin and give her control. Perfect. All right, Erin, take it away.
Thank you so much. And Amy, I really appreciate all, like, just the depth of knowledge that you have makes me feel like we could probably talk about this subject for a couple more hours today. So I will also try to stay within my time so that we have time for the good questions at the end. As the dietitian, when I am seeing a patient after they've had a stroke, whether it is in the ICU just after the event or in a post-acute rehab setting, or maybe even consulting further on down the line, our overall goal is to help that patient keep their body and their mind strong. It can be such a long journey, as Amy was touching on, that it's not just those first 3 months when we see spontaneous recovery, but really getting back to the patient's normal, or helping them adjust to what their new normal is. We want them to feel like their body is physically strong. They're able to do the activities that they want to in a way that feels like they keep moving forward. So today I'm going to touch on some of the barriers to adequate nutritional intake after an event like a stroke. We'll talk about the consequences that that can lead to, and then some actions that you can take across various settings to help mitigate the nutritional risk that these patients experience. There we go. Okay. So it's not just potential swallowing problems that can prevent a patient from getting adequate nutritional intake after a cardiovascular accident, though, of course, that can be a really significant barrier. And we'll talk a little bit more about that in detail. But, put yourself in the patient's shoes after you've had a major event. You may now be in a completely unfamiliar environment with unfamiliar caregivers around you, and you're being served likely unfamiliar foods. Um, Healthcare facilities have quite limited flexibility for how they can prepare food for patients, and particularly on the modified diets, it may become very repetitive, and there are certainly options that may not fit with a person's personal diet preferences or restrictions that they already have, and may be difficult to fit with their cultural and religious beliefs as well. Other things that may be going on with the patient, again, things Amy touched on, like the inability to focus or complete tasks at meal times. We may even have patients that on down the line don't have the executive function to remember to plan meals and may miss meals entirely. Particularly in facility settings, I see patients with their days and their nights mixed up. And so that leads to sleeping through meal times. Patients may also have lost their ability to feed themselves, or, and I saw this on one of Amy's slides that was so important, is they may experience significant fatigue during the meal itself. And if you have a patient that's taking longer than an hour to eat a meal, then they are certainly not going to get enough calories in throughout their day. Mental health is also a very important part of this person's holistic care. As Amy touched on as well, depression can play a role, and it can set in very quickly for a person that has had, a major change in their lifestyle and their ability to live life that they really want to live. So it's something that we definitely need to keep in mind, because depression from any cause can certainly affect appetite as well. Sorry, these seem to be taking a while to advance my slides here. There we go. Okay. So it doesn't take long for malnutrition to set in for these patients. So as a matter of fact, we've only really had a good consensus definition of malnutrition in the literature since about 2012. There are a couple different definitions out there, and many facilities choose to pick one and stick with it for diagnosing purposes. All of them consider whether a patient has had a decreased PO intake over a certain amount of time, whether they've had a certain amount of weight loss over a time period, and a physical exam, which, when done by a trained clinician, can identify whether there has been loss of lean body mass and subcutaneous fat loss. Anytime you have a patient who is losing weight unintentionally, that is a bad thing. And it does not matter what weight the person starts out at. And that is because when we are losing weight unintentionally, it's because we're not getting enough nutrition, and our body is going to its richest resource, which is our lean body mass, to get that nitrogen, which is the key structure for proteins, DNA, nucleotides, all of those things. So very quickly, these patients start to lose the integrity of their skeletal muscle, which is, of course, strength, conditioning, activity, balance, and dependence, right? They also start to lose skin integrity very quickly. Amy touched on the fact that thickened liquids really, really aren't appealing, especially if you have to have all of your liquids as thickened. So a significant dehydration risk exists. When you get a patient who is in the realm of malnutrition and dehydration, they are at higher risk for pressure injuries, nosocomial infections. Their length of stay goes up. They will be rehospitalized more often. They use more resources of our healthcare facilities, and ultimately their mortality does go up, particularly at the 6-month mark. It's important to note as well that about 30 to 50% of our patients come to the hospital in a malnourished state. So many of these patients are really starting from behind when we first meet them. So it's important that in our process of caring for these patients' nutrition status, that we're screening everyone that we come in contact with for nutrition risk. There are several published validating screening tools available. All of them are about 3 to 5 questions that ask the patient about their recent PO intake, whether they've had any unintentional weight loss recently, and ask the clinician who's doing the screening to score the disease severity. This usually generates either a numeric score, sort of a yes or no, and then your facility can use that to trigger a nutrition assessment with the registered dietitian. I'll talk about what the dietitian's going to do once they get the consult for that assessment. But other things that the team can do is make sure that we're regularly assessing for GI symptoms that need to be treated. Things like nausea and constipation. It feels like that's just what happens to you when you come to the hospital. Now, there's reasons for it, but we can also treat those, right? We do need to assess for that depression early and often and treat it. We need to support sleep hygiene for these patients. Get them up during the day, open the curtains, help them see some daylight, and then help them sleep at night, preferably uninterrupted. And then it's very important, particularly for our patients who are on these modified diets, that we reevaluate the need for any diet restrictions on a regular basis. I really liked Amy's emphasis on which of your patients can be appropriate for ice chips and sips of cold water so that they can continue to progress and exercise that swallow. The sooner we get them off that modified diet, the more food choices they're going to have and the better they're going to be able to eat. So when your dietitian sees patients, these are some typical things that we will start to recommend. I like oral nutrition supplements as a tool in our toolbox because they are higher calorie, higher protein beverages that can be easier to consume than asking a patient to eat more often throughout the day or even to eat larger portions at their meals, particularly if their food's already unappealing to them. So, the familiar brand names that are out there, Ensure, Boost, Glucerna, Premier. Gelatine is a high protein jello that doesn't melt to a thin liquid. Magic Cups are ice creams that don't melt to thin liquids and have a little bit of protein added to them. The best option is really the one that your patient will take on a regular basis. And maybe it is a variety of them. Or maybe it's something even that the family brings into the facility for them. So that's a way that we can meet the patient where they're at and with their preferences and work with families if we also make sure that it's safe for them. However, a lot of these products are sweet and cold, and that's not should have savory and hot foods and avoid cold and sweet foods. So it can be a little challenging. We may also schedule snacks that are higher in calories and protein, particularly if the patient doesn't like a protein drink. I use a lot of cottage cheese, a lot of yogurt in my practice. We do a lot of half sandwiches. Even a peanut butter and jelly can go a long way. Those will work best for patients who don't need the modified texture diets or only minimal modifications. And you can have a problem with a limited variety of snacks in healthcare facilities, but you may be able to work some in. If you do have a patient who requires tube feeding, we will do our best to to schedule that tube feeding around their therapies. In the hospital, I can make sure that they have a half hour here and there off to work with therapies. And certainly in post-acute rehab, where their therapy sessions are much longer, we can cycle the tube feeds overnight. We'll often be recommending vitamin and mineral supplements to make sure their micronutrient needs are taken care of. And something else to keep in mind is if you have patients who have been in a facility for greater than 30 days and they have not been outside, they are at risk for a vitamin D deficiency. So something to talk with the provider about. My apologies. Sometimes these slides are advancing and sometimes they are not. There we go. Okay. So a therapeutic diet, we especially see these in the hospital, but sometimes they follow the patient to post-acute rehab or even skilled nursing facilities. And these are the diets that restrict a specific nutrient in order to help manage a specific disease or disorder. So for instance, our patients with congestive heart failure or renal failure may be on a low sodium diet. Our patients with blood sugar control needs may be on a consistent carbohydrate diet. The thing about these diets is that, especially if they are given on top of a modified texture diet, they can severely limit, again, the number of food options for our patients. So my ask of my patients is that they prove to me they actually need this restriction. So I will talk with the providers about making sure we control any issues with medical therapies as much as we are able to. When I'm checking on their actual intake, if they're eating less than 3/4 of their meals consistently, then the diet's not the problem. If I have a patient who, just for example, if they have an outrageous potassium level, I'll go talk to the patient. And if it turns out bananas are their comfort food, then we'll have to come to an understanding about how many bananas they can eat in a week. And I'll offer some alternatives, but I'll still do my best not to limit potassium to 2 grams a day. And then we'll follow their labs to continually reevaluate whether these restrictions are necessary. And then for the modified texture diets, again, referring to things like purees, minced and moist foods, or soft and bite-sized meals. Just something to know if you're not familiar with how they're taken care of in food service. Many facilities are buying these food items pre-made. They are not being made in their kitchens. And this is important because it does offer consistency for safety so that your morning line cook and your afternoon line cook aren't worried about exactly what size that soft and bite-sized entree needs to be. And beverages likewise may be purchased as pre-thickened items. But the problem with this can be that it really limits the customization that we can do for our patients. And it's important to remember, and depending on who you ask, that texture accounts for at least 40% of our eating experience. It really helps us identify the food that we're actually eating. So again, reevaluating the patient's ability to swallow is important to make sure that we are able to give them the broadest variety and offer the most options to meet those calorie and protein needs. If you do get a patient who is really struggling and you may be thinking, well, is it time to consider tube feed for a patient? It's important that we look at the prognosis of the stroke pathology. We do know that some types are going to present with more severe and more prolonged inability to swallow versus those that may resolve within a few days. That knowing about that patient's baseline nutrition status, so going back to that nutrition screening and having the dietitian do a full assessment at the beginning of the patient's stay can help you determine when really do you need to know whether or not this patient needs a tube feed. A well-nourished patient can wait up to a week as long as we're supporting with IV fluids. Whereas a malnourished patient should be started within 48 to 72 hours if they're unable to take any PO at all. And often when I'm in this realm of like waiting to see if a patient's going to need a feeding tube, I'm still doing my other therapies. We're still offering whatever oral nutrition supplements are safe for them at the time, and what other modified diets may be safe for them at the time to see what we can do to get them to eating enough. But these are the timelines within we should start to consider whether or not a patient needs a little extra help. Of course, we should be talking with the patients and the patient's family about their overall goals of care. And we may be considering whether we're just placing a temporary nasogastric feeding tube, something that we would provide for the patient just for a few weeks to help bridge them back to being able to take their calories via oral intake, versus something that's more semi-permanent or permanent in a percutaneous tube. When we're considering whether or not a patient should get a percutaneous tube, we're looking at whether a patient needs those enteral feeds for at least 2 weeks. We're usually looking at it in our facility in that 2 to 4 week window. And the reason is my providers who place these percutaneous tubes like the tube to be in for at least 4 weeks to make sure that the tract is mature, so that when we remove the tube, when the patient no longer needs it, it heals well. I often talk to patients about how these tubes can be considered semi-permanent and not necessarily permanent. When you first introduce this idea to a patient or their family, they may often go straight to, oh no, I'm going to be on tube feeding for the rest of my life and I'll never eat again. But instead, we just talk about the fact that it may be 4 weeks, 6 weeks, or a few months, or maybe a little bit longer. But the idea is at least to bridge and help you continue to rehabilitate. Because again, our overall goal is keeping this patient's body strong, and we can't do that without meeting their calorie and protein needs. It's important that we don't wait, though, until the patient is severely malnourished to consider it, if possible, because it is still a procedure and there is risk putting a patient who has lost a significant amount of their skeletal muscle through this procedure to have it done. What else can you do working in your facilities? It's great if you can advocate with the food and nutrition services manager for more variety in your, especially your modified texture diets. Ask them to bring on more culturally sensitive food items. Look at the population that you're serving and what's important to them when they are sick. So for example, our facility has been able to bring on congee, which is a warm, savory rice porridge that's very important to several different types of Asian cultures when they are feeding their sick loved ones. Communicate with the supportive family members. Obviously, we want to educate on required diet textures for when the patient is going into their care and leaving our facility. But maybe even while they're still with us, can these family members be taught to bring in some appropriate food that, again, meets the patient's preferences a little better? And I ask this of all healthcare workers. It's really important that we don't demonize individual nutrients. It is very frustrating when I overhear a nurse or any other staff member saying to the patient, "Oh, you have to drink some Ensure. That stuff is so gross." No, that stuff may be absolutely necessary for that patient to meet their calorie needs. And patients can be scared off by fad diets, like things that are high in sugar or high in fat. They're not good for you. And look how much sugar Boost has in it. That's not sugar, that's carbohydrate. And that's a necessary energy source that is, again, going to help a person maintain their strength when they're not able to eat it otherwise. So be careful how you talk about foods around these patients. Now, I'm almost to my time, and I definitely want to leave some time for questions, but I also want to just give a little shout out to a couple of our heart healthy diets that have stuck with us over the decades that we know can help us all prevent a cardiovascular event. So when a patient gets to that long-term place and they just want to know, how can I stop this from happening again? We can talk about the DASH diet, which stands for Dietary Approaches to Stop Hypertension. This is a diet that focuses on high potassium, high magnesium, and fiber intake from fruits, veggies, whole grains. We want more lean proteins in the diet. And what we're limiting here specifically is some sodium and sweets and sugar sweetened beverages. So a lot of good plants in here. And it's important to note that while, in general, we know that decreasing sodium intake can help control blood pressure for some people, what we have learned through the DASH diet is that increasing potassium and magnesium is also significant to controlling blood pressure. So it's also about what we're adding to our diet, not just what we're taking away. And likewise, the Mediterranean diet is another place where we know study after study after study through several decades has shown us that a diet rich in veggies, fruits, beans, whole grains, um, vegetable oils in place of animal fats, and animal proteins that focus mostly on fish and poultry and a little bit of low fat dairy. Those are the diets that in general are going to feed our whole body and give us those good anti-inflammatory nutrients. And so with that, I have just a few resources to share. And that's my time. Thank you.
You, Erin and Amy, both amazing presentations, and I think really um, played well to, like very well integrated into and kind of what we're doing in speech therapy, especially from the swallow but whole person standpoint, right? And all of the things that we can do to make sure we address the patient as a whole, and then Erin really tying that into the nutrition standpoint. Um, I'm going to stop sharing my screen and I will show my face again. Does anyone have any questions? I haven't seen anything pop up in the question and answer box yet, but please feel free to throw any questions in there that you have for Amy and Erin. Um, while we wait, I just wanted to, I really liked what you said at the end there, Erin, about not diets and what can you add, because like you mentioned, a lot of what happens after a stroke is things kind of get taken away from patients, and then with diets, if we're restricting, it limits the options and then can kind of add to that depression cycle and that losing the joy in eating. So I like that, framing that, what can we add to improve the nutrition. um what about things, Aaron, like bone broth and things like that? I know patients ask me about that, especially those patients who don't really like the sweet um, taste of like Ensure or those other shakes. Is bone broth a viable option for people who want more protein?
Yes, absolutely. I do like bone broth. It is so bone broth, for those who maybe aren't familiar, are broths that are made where the bones from the animal are simmered in the liquid for a longer period of time than just your standard kitchen stock or broth. And so a couple of things. Naturally, it's bone broth, so it is made from animal products, so usually chicken or beef, and it has about anywhere between 8 and 10 grams of protein per 8 ounce serving, compared to, again, a regular broth, which usually has like 0 to 2. So it is an option. It can be, it's low in calories because there's not much else to it. It can be thickened. So that's a nice choice there too. When we had it available in our facility, I would often serve it with soy sauce. To give it a little Asian flair for some of our patients. So yeah, it's a great option, and it's about finding a bunch of kind of small things like that that really help to add up. And that's why I encourage, all different types of clinicians to go to the food and nutrition services manager and advocate for this. I'm sure that your dietitian is too, but it really helps to have more voices talking about where there are missing pieces to what the patient's needs are.
Yeah. But Amy, Aaron, do you guys have any questions for each other while we wait to see if any other questions come in through the Q&A?
I'm curious, Erin, if you've worked at different facilities. I know that here in Hawaii, there's sort of a different medical culture, and I find that a lot of providers and patients and families are really averse to tube feeding, just in general. You want to avoid placing the NG tube or the dob off, really want to avoid peg tube placement. And I'm curious if you've worked at different facilities, if you notice, have any thoughts or comments about that.
Amy, I think that it really depends on how the team presents it to the patient. And I agree with you. I've met some providers that really feel like it's so invasive to have that tube in your face, or it's so invasive. Um, Obviously these decisions can't be made lightly. On the other hand, if I can demonstrate that the patient is, meeting only 30% of their calorie needs or 50% of their calorie needs, especially now that we have really good concrete evidence-based definitions for malnutrition, which, like I said, have really only been around for the last decade and a half or so. Now that we can really clearly define that, I'm definitely getting more clinicians on board with the fact that we need to prevent malnutrition rather than let it happen first and then address it. I also like to talk with families again about it being a bridge. And for some families, they can really start to understand how it takes the stress of eating off of the patient so that they can focus more on their various therapies.
A great point, Erin. And I know we've chatted a little bit about this because there were some talks at International Stroke Conference this year about timing of peg placement, but really kind of sometimes the lack of follow up on the outpatient side. So we think, okay, we're doing this and we're getting this bridge, and sometimes um, patients don't know how to advocate for themselves well enough to say, okay, I'm ready to get it out because I'm eating, and they don't always get that follow up. So making sure we educate our patients and families to advocate for that follow up. Okay, they've discharged from a sniff, they're eating a diet. Reevaluate with a dietitian. Have them advocate to their doctor to get an appointment with a dietitian to make sure that they are no longer in that malnutrition status, and then talk to their doctor about removing that peg tube.
Yeah,
Yeah.
agreed. And I think we as the team also need to be aware that if we're counting on the primary care provider to be managing it after the patient leaves all of our rehab environments, that can be really tricky because not every primary care provider has a lot of experience with feeding tubes, where compared to someone who may be getting a feeding tube for a gastrointestinal reason, the GI team has a lot of experience with it. So making sure that can we connect with that PCP and send over my notes and let them know that, like, hey, I think this is the timeline for reevaluating. And if the patient is maintaining their weight and eating about this much, that you can go ahead and take that tube out.
Mm-hmm. Yeah.
I do have one quick question, recognizing that we have 3 minutes left, but I'm curious, Erin, if you can provide any quick examples of successful transitions you've seen from tube feeding to oral intake. For example, and I know that this is patient specific, obviously, but if the patient eats so much, then they can skip a bolus, tube feeding, etc. Any comments regarding that process other than consult your RT?
Oh yeah. Oh yeah. So the way that our transitional feeding often goes is that we, particularly if you've got a patient on bolus feeds or even on nocturnal feeds, you start to watch closely exactly how much they're eating at each meal. And I got to tell you, family members are pretty good at understanding that, okay, they used to eat only a few bites at breakfast and now they're eating at least half of their breakfast and now they're eating half of lunch as well. And so in those cases we'll often write a plan for them that's like, okay, exactly as you said, if they eat lunch they can skip a carton. If and then and it just kind of blossoms from there typically. I also have some patients who kind of, it's almost like a light bulb goes on where they sort of get to a place in their rehabilitation, and it's often in that sort of that 3 months, spontaneous window where, hey, this week I started eating and I'm too full for my tube feeds, and okay, let's check your weight, let's see how it's going. And it, um, if they can maintain that for a couple of weeks, and a lot of times it takes a while to get your appointment to get the tube removed, so usually you have a few weeks where you can just flush the tube with water to keep it clean and not use any feeding at all. And if the patient continues eating consistently and maintains their weight, that's a pretty good sign.
Yeah, that's
And
great.
some of my patients just decide they're done with it too. And so in those cases, then we have a little conversation about, like, okay, well, then I'd like you to drink 2 protein shakes a day. But if they're at that point, then that's great.
Yeah, and on that, Erin, it goes back to that patient centered. What do they want? They drive the bus. We're just there to provide recommendations and information, and they get to make those decisions based on that.
Totally. A good analogy for that is my skills are like a buffet. You can take what works for you.
I love that, Amy. I might start using that. All right. Well, we're at about time, and I don't see any other questions in here. So thank you, Erin and Amy. Really appreciated both of your knowledge and expertise. And hopefully we'll be able to engage with you guys and do something like this again. Maybe we'll add a little bit more time, because I know you guys have a lot more you can talk about.
Thank you so much.
Thank you. This was a wonderful opportunity.
Thank you, guys. All right. I hope everyone has a great day. Thanks.